Hello everyone. Pancreatic neuroendocrine tumors are rare, but they are clinically fascinating entity. One patient may present with recurrent hypoglycemia and seizure, another with refractory peptic ulcers, another with liters of watery diarrhea, and another with silent pancreatic mass with liver mets. The key to understanding PNETs is simple. First, decide whether the tumor is functional or non-functional, then localize it, grade it, stage it, and plan the treatment. In this video, we will simplify the PNETs for medical students and trainees. So this is a very basic level talk meant for the trainees and basically medical students, from clinical presentation to investigation, prognosis and management. So theoretically, then some case discussion and questions, so that this will be a comprehensive video covering all the aspects of PNETs. Please read the detailed disclaimer and description. These videos are meant for education purpose only, and these are not a substitute for professional training and professional advice. And friends, for an exclusive and early access to our premium high definition content, please download our app Android or iOS or join the channel membership. The link for everything is given in the description of this video. Please check it out. So in this series, we have already uploaded few videos about the general NEC, basically non-functional NET, Insulinoma. Please check them out so that you have a better background knowledge of this entity, the things we have already discussed on our YouTube channel and on our app. So now let's start with this PNET episode, Clinical Features, Investigation, Prognosis, Management 2026 update. So now I will give you some clinical scenarios. Some are basically real time, some are not so real time, imaginary. So you have to pause the video at times, make your diagnosis, then move to the next part of the video. So first is case number 1 is classical presentation, real life case. So that means this case was managed by us. So this 44-year-old lady homemaker presented with episodic sudden loss of consciousness for last 5 years, history of generalized tonic-clonic seizure, symptoms amyloid after taking sugar, evaluated in local hospital, found to have hypoglycemia. There was no history of loss of appetite, weight loss, no history of jaundice or GI bleed. So what it can be? So this patient was evaluated extensively for the psychiatric illness because she was becoming unresponsive, or there was a confusion of symptoms at times. There were no other positive history, and she consumed mixed diet, and her family history was not contributory. So this patient was started on bisolone, I think, for the hypopituitarism. There was some improvement in the symptoms, maybe because of the hyperglycemic effect of the steroids. Then she was evaluated in the department of endocrine, managed with dioxide, starch-based, corn-based diet, and blood sugar monitoring. And then after that, she was referred us for the surgical evaluation. So dioxide, as I said, it suppresses the insulin secretion and is symptomatic management for the hyperinsulinemia by direct action on the beta cells. So I hope the diagnosis is itself clear from the history. On examination, patient is conscious, comfortable, oriented, and alert. BMI was 27.56 kg per meter square. As such, she was on the overweight side. So they learned to eat to survive. The general physical examination was normal, abdominal examination was normal, and rest of the systemic examination was normal. So this patient was evaluated for basically insulinoma, and MEN work was done. Those rest of the marker like cortisol, the TSH, ACTH, GH, serum gastrin, PTH, prolactin were normal. Her fasting blood sugar was found to be 35, and the serum C-peptide was 3.01. The insulin fasting level was 14.10, all indicating towards the basically insulinoma diagnosis. The rest of the parameters were normal. As I said, the ME1 workup was normal, so it is not a syndromic insulinoma. You have to read this, otherwise ME1 you have to read parathyroid, pancreas, pituitary, foregut. All these things has to be evaluated while you are suspecting a diagnosis of ME1, specifically in the case of pancreas, insulinoma, gastrinoma, and other tumors. So this is the investigation. This patient was done. Ultrasound was normal. MRI cranial, think of the psychiatric illness, it was normal. Triple phase CT was normal. I'll share the pictures and then the picture will become clear. Otherwise they reported no pancreatic as well. So this CT scan, triphasic CT scan of the abdomen of this same patient was reported normal. So when we were seeing the pictures, I hope you can make out, you can see there's a subtle bulge with the enhancement in the superior surface of the pancreas, just distal to the neck. In this single picture, I mean this enhancement and bulge is even clear. Same is here. So I hope you could make out. This is a labeled CT scan image. So there's an arterial enhancing lesion noted the bulge missed out that was missed out on the initial CT scan. There's the MPT was prominent just below the bulge. Portal vein and rest of the splenic vein were normal as marked. So hypervascular to the normal pancreas and arterial and pancreatic parenchymal phase. This is highly suspicious for the neuroendocrine tumor. This patient was planned for the PET scan. So as I said, the DOTA scan, the DOPA scan, DOTA TET, DOTA NOC, they are specific of the pancreatic neuroendocrine tumors. And latest addition is 68 gallium exendin scan. So on that scan, there is a very good uptake as seen on the left side of the picture. The upper is the DOPA scan, lower one the exendin scan. Look how beautifully it is enhancing with these scans. And on normal CT scan, there is only subtle bulge. So that is how these investigation DOTA, DOTA NOC, DOTA PET, exendin, they have become the gold standard now for the diagnosis of the these neuroendocrine tumors. The diagnosis is insulinoma, classical presentation. So in this case, we did central pancreatectomy with root by pancreatic neuroendocrine for this lady. So there were no other lesions. There were mass in the body of pancreas. We did central pancreatectomy. The proximal part was cut with the help of stapler. Distally, we did the PJ, root by PJ with dunking method. So these are the basically diagrammatic representation what we did for this patient. Central pancreatectomy with root by pancreatic neuroendocrine for the distal stump in a dunking manner. So these are the intraoperative pictures and the vascular tumor is evident. This is the resected specimen. So friends, I mean the key points in this case are this is a typical case of insulinoma, most common functional PNET, the classical people tried was there, hypoglycemia, documented low blood glucose, and relief after taking the glucose, 72-hour fast test. Diagnosis can be confirmed by drawing plasma glucose, insulin, C-peptide, proinsulin level during 72-hour fast. This panel will detect 90% of insulinomas. Key to diagnosis, serum insulin, proinsulin, and C-peptide. More than 90% insulinoma are solitary, benign, and surgical resection curative. Like in this case, the differential diagnosis you have to remember is factitious hypoglycemia and dumping syndrome. In factitious hypoglycemia, patient will be taking injecting insulin in him or herself, but that can be picked with the help of proinsulin and C-peptide. So friend, this is the next case number 2. Again, the rule is same that you will analyze the case before moving forward and make your diagnosis based on the discussion we already had in this video. So friends, 42-year-old male, the history of multiple recurrent peptic ulcers and severe GERD, presented with abdominal pain and chronic diarrhea. So patient reported to have peptic ulcer disease for several years. He was taking PPI around the clock, which was unresponsive to high dose of PPIs, also complaining of chronic diarrhea and weight loss. So the serum gastrin, which was 2000 picogram per ml, markedly elevated. The gastric pH was less than 2, hypersecretion or gastric acid. Secretin stimulation test further increased the gastrin level. Imaging CT and MRI, 2.5 centimeter mass in the head of pancreas. PET scan, positive uptake in the pancreatic mass. A metastatic lesion in the liver. So the diagnosis is itself glaring. It is Gastrinoma or the Zollinger Ellison syndrome. So we manage this patient with the surgical resection of the pancreatic mass with the liver metastatic debulking, and patient was also managed with the high dose of PPI. Post surgery serum gastrin level decrease and symptom of the GERD and diarrhea improved. So we did the resection plus the metastectomy. Coming to the case number 3 now with liver mets. I hope you can make out the diagnosis with this line only. So a 60-year-old man Presented with vague abdominal pain, unintentional weight loss, and early satiety. There was no significant past medical history. He also gave history of this non-specific discomfort, pain for last several months without any other positive history of jaundice or upper GI bleed. So we evaluated this patient on ultrasound. There was a suspicious lesion in the liver and tail of pancreas. CT scan abdomen showed 4 centimeter mass in the pancreatic tail, multiple lesions in the liver, so history of METs. Chromogranin A was elevated, non-specific marker for the NET, so it was elevated around 170. Biopsy of the lesion confirmed NET, non-functional. Ki67 was 5%, so it was a grade 2 PNET. So, it is a non-functional PNET with the liver mets, but can be the management, friends. Just plan management for this patient before moving forward. So, this is a very extensive disease. There are multiple liver mets. The primaries, the debulking is not possible in view of the extensive liver mets. So, this was patient was treated with a somatostatin analog octreotide. There is a octreotide depot injections comes, which patient can take every monthly. That control the tumor growth, and later this patient was expected to the PRRT, that is peptide receptor radionuclide therapy. And with that, patient showed partial tumor response. Disease became stable, and symptomatically patient was better. Patient is on a regular follow-up. So, non-functional PNETs, as we discussed, they are often diagnosed late, usually with the METs. They do not produce any kind of specific type of hormone, so the detection is delayed. And presence of liver METs at diagnosis often dictate the therapeutic approach, because if they're solitary MET, or if we can take out the most of the disease, then we can offer the surgery. If there are multiple bilobar involvement, then usually the medical management is the choice of treatment. Coming to the fourth case, friends, this is a rare presentation. So, 45-year-old lady presented with rash, weight loss, and new onset diabetes. So, if you have gone through the video so far, you should be able to make the diagnosis with these 2 lines only. She complains of itchy erythematous rash on her lower abdomen, thighs, unintentional weight loss, polyuria over past 6 months. There was a rash, polyuria, and unintentional weight loss. I hope you could make the diagnosis. This was something similar to the case which was published in NEGM, which we have discussed, that is the necrolytic migratory erythema specific rash with diabetes mellitus. Polyuria was because of the diabetes mellitus and unintentional weight loss. So this is a basically case of glucagonoma. So these were the investigation. Fasting blood glucose 189, mildly elevated. Serum glucagon level was 1500 picogram per ml, elevated. Skin biopsy rash shows necrolytic migratory erythema. Imaging MRI of the abdomen shows 3.5 centimeter mass in the pancreatic body. So the diagnosis is glucagonoma. So we did the surgical section for this patient. The diabetes was managed with the help of insulin in the pre-op stage. Nutrition was improved. Post-op stage, glucagon level normalized, rash resolved, and diabetes was well controlled post-surgery without insulin, and the rash did not occur. So the key points for glucagonoma is it's a rare PNET, extremely rare. I think less than 400 cases reported so far in the literature. There is a characteristic rash, necrolytic migratory erythema, and weight loss, mild diabetes. Recognizing skin manifestation lead to the early diagnosis. So, like in this case, the skin biopsy of necrolytic migratory erythema was diagnostic. So, this is the case number 5, last case, a life-threatening presentation. Again, you should be able to make diagnosis based on this one line. So, a 50-year-old man presented with profuse watery diarrhea, dehydration, and muscle cramps. So, on the history, patient was having watery and non-bloody diarrhea for several months with up to 10 liters of stools per day. There was a history of significant weight loss, episode of muscle weakness. On investigation, the serum BIP levels were markedly elevated. Blood test shows hypokalemia, metabolic acidosis, and dehydration. Imaging CT scan revealed a 5 cm mass in the pancreatic tail. Diagnosis is BIPOMA, the Burner-Morrison syndrome, or WDH, watery diarrhea, hypokalemia, achlorhydria syndrome. So patient was managed with aggressive fluid and electrolyte replacement. Octreotide was started to basically antagonize the action of hormone. Surgical resection of tumor was performed after stabilization, and post-operatively diarrhea resolved, electrolyte levels normalized. The key points are lipoma cause profound watery diarrhea leading to severe dehydration, electrolyte imbalance. WDHA syndrome we have already discussed. Timely diagnosis and management with somatostatin analog and surgery crucial. So watery diarrhea, hypokalemia and achlorhydria, WDHA syndrome, or the the Morrison syndrome. So now friends, this is the end of the discussion. If you have any doubt or any question, you can always ask in the comment section on YouTube or in the chat option on the app. So we will be happy to answer whenever, whatever we will share with you. So the question number 1 is, PNETs arise primarily from ductal epithelial cells, acinar cells, islet cells of Langerhans, or pancreatic stellate cells. The answer is C, pancreatic neuroendocrine tumors. Basically, the neuroendocrine neoplasm arising from the endocrine islet cells, they differ biologically and clinically from ductal adenocarcinomas. PNETs account for approximately what fraction of all pancreatic tumors? Answer is C. PNETs are rare compared with the exocrine pancreatic tumors. Classical teaching is 1 to 2% of the pancreatic tumors are PNETs, the rest are PDAC. Most common functional PNET is, so answer is B. Insulinoma is the most frequent functional PNET and commonly present with fasting hypoglycemia. The best classical triad for insulinoma is, so the answer is C. Whipple's triad defines clinically significant hypoglycemia with neuroglycopenic autonomic symptom relieved by glucose. So during a supervised 72-hour fast, the biochemical pattern supporting insulinoma is, so the answer is B, that endogenous hyperinsulinemia shows inabruptly high insulin and high C-peptide when glucose level is low. This is an important question. Factitious hypoglycemia due to exogenous insulin typically shows, so the answer is B, that injected insulin raises insulin but suppresses the endogenous secretion, leading to low C-peptide and low proinsulin level. So that is the catch, that in endogenous hyperinsulinemia, both the insulin and C-peptide proinsulin level will be high. The rule of 10 for insulinoma most appropriately means, so it is basically, answer is B, and it is not a rule, it is an exception. Multiple insulinoma should prompt evaluation for, answer is B, ME1 syndrome. Multiplicity strongly suggests ME1 association, parathyroid, pituitary, pancreatic endocrine tumors. Gastrinoma cause symptoms mainly due to, so answer is B, excess gastrin lead to hypergastrinemia, marked acid hypersecretion, that is refractory and multiple ulcer, diarrhea and malabsorption. Most sporadic gastrinomas are located in, we have already covered all these questions, all the questions that were asked, I have already answered in my video. So answer is B. The gastrinoma triangle or the Pissarro triangle concept indicates, answer is B, region where 90% of gastrinoma arise. Most gastrinoma occur within the anatomical gastrinoma triangle, classical surgical anatomy. Best single differentiator of gastrinoma versus other cause of hypergastrinemia is, so again we have already discussed, the answer is B. Gastrinoma, high gastrin, high acid, low pH, atrophic gastritis, and BPI, high gastrin but low acid and higher pH. Hypergastrinemia with the low gastric acid output is most consistent with, we have just discussed. Answer is B, atrophic gastritis oblique pernicious anemia, parietal cell loss, achlorhydria, compensatory hypergastrinemia. Secretin stimulation test in gastrinoma classically shows, so answer is C, Paradoxical increase in gastrin after creatine supports Gastrinoma is used when fasting gastrin is equivocal. Pipoma syndrome is best remembered as, it's simple. Answer is A, WDHA syndrome, watery diarrhea, hypokalemia, achlorhydria. That is the Werner-Morrison syndrome. BIP causes watery diarrhea mainly by. So answer is B, increase basically intestinal cycle AMP that leads to secretory diarrhea. A key clinical clue suggesting secretory diarrhea, that is Bipoma or Werner-Morrison syndrome or WDHA syndrome is. So answer is B, secretory diarrhea continues during fasting. Osmotic diarrhea improves. So this is the one of the hallmark of the Werner-Morrison syndrome. Glucagonoma is classically associated with. You cannot forget that picture of NEGM. The answer is A, necrolytic migratory edema plus diabetes and weight loss is hallmark. So at diagnosis, glucagonoma most commonly has. Answer is C, most of the glucagonomas present late and they have liver mets at presentation. The classical triad with Somatostatinoma 3S includes. So answer is A, stone, sugar, steatoria. Somatostatin inhibits insulin GI excretion and leading to diabetes, steatoria, because the pancreatic inhibition and also gallstone from the reduced gallstone motility. So all these things we have already discussed in the theoretical discussion of this video. This is a repetition. Next question is non-functional PNETs most commonly present with. So answer is C, non-functional PNETs lack a hormonal syndrome and are usually discovered very late with usually mets. A commonly used but non-specific marker for a non-functional NET is B, chromoglobin A can be elevated but is non-specific, can rise with PPI and renal failure. The best first-line imaging for localizing or staging of suspected PNET is. So B, CT scan oblique MRI. They detect hypervascular primary tumor or METs. PNETs are typically best seen on CT during which phase? So C, arterial phase, because they are hypervascular, avid arterial enhancement is seen. They light up on the with contrast. Endoscopic ultrasound is most useful because it is. So B is the answer. It can detect very small lesion up to 2-3 mm and even tissue diagnosis is possible with USFNB. Again, similar question. A major advantage of US over CT MRI in PNET workup is. So answer is B. You can have a tissue diagnosis also along with the imaging. The gold standard functional imaging for somatostatin receptor expressing NET is. Come on. We have already discussed it. So answer is B, gallium DOTA PET, DOTA NOx, basically DOTA based studies. They are high sensitivity specific for SSTR positive NET and is preferred over the older scintigraphy. Octoscan, that SRS old scan works by. Answer is B, binding to the somatostatin receptor with radio level analog. Next, angiography can localize PNETs because they are. Next is on histopathology. Neuroendocrine tumors classically show. C, stippled or salt-ridden paper chromatin is characteristic of the NETs. Most useful confirmatory IHC marker for NET includes. So B, chromoglobin A and synaptophysin are the key neuroendocrine marker. Ki67 aids in grading. Do remember that. The WHO grading of well-differentiated PNETs are usually primarily based upon. So I hope you remember it's B, Ki67 proliferation index and mitotic count. Ki is less than 3, 3 to 20, more than 20, and mitotic is less than 2, 2 to 20, and more than 20. Pancreatic NET grade 1 defined by Ki67 less than. So less than 3% Ki and less than 2 mitotic count. Answer is A. A well-differentiated pancreatic NET with Ki67 more than 20% is. So we have discussed this in a table. So this answer will be B, well differentiated NET grade 3 if the architecture is preserved. If the architecture is not preserved, poorly differentiated, then it will be NEC. Poorly differentiated pancreatic NEC is typically, come on, we have already discussed this. So NEC small oblique class L 2 type is aggressive with poor prognosis and often needs systemic chemotherapy. They are usually not amenable for any surgical resection. Best overall curative option for localized PNET is surgery. Option B, resection is the treatment choice for all localized disease. Approach depends on the size, site, grade, and function. So whenever we can take out the disease, we have to offer them surgery. Enucleation is most appropriate for, remember the case we have discussed. So B, small tumor less than 2 cm, low grade, grade 1, grade 2 may be close to the surface. A key surgical criteria favoring enucleation is tumor distance from main pancreatic duct. We already discussed. Option B, must be 2 to 3 mm away from the PD. Close proximity to the MPD increase fistula risk. So intraoperative ultrasound helps define the duct relation. So tumor in the head of pancreas requiring oncological resection most often needs. Option B, that will be Whipple procedure. Tumor in body tail of pancreas requiring resection often needs. Option A, distal pancreatectomy, friends. So body tail lesion typically treated with distal pancreatectomy depending on the oncological context and may require splenectomy also. Most common metastatic site from PNET is liver. Option C, most common site on METs strongly impacts prognosis and strategy, whether single, multiple, single lobe, bilobar. A patient with metastatic SSTR positive well differentiated PNET is candidate for. Again, we have discussed option B, PRRT, that is the peptide receptor radionucleotide therapy. Again, this is very good modality for the metastatic lesion where the surgery is not feasible. Somatostatin analog octreotide, lenalidomide are primarily used to, as I said, they are the gross inhibitors, static tumors. So they are controlled hormone symptoms and slow tumor growth in SSTR positive disease. Option B, everolimus used in advanced PNET targets the mTOR pathways, friends. Everolimus is mTOR inhibitor used in progressive advanced PNETs. Sunitinib benefits advanced PNET primarily through. Option B, tyrosine kinase inhibitor, TKI inhibitor, anti-angiogenic. A commonly used modern chemotherapy regimen for advanced well-differentiated PNET is option B, Captam, that is captamine and temozolomide, widely used in pancreatic NET, especially progressive and metastatic disease. Streptozocin-based chemotherapy in PNET is classically combined with option B, doxorubicin. So streptozocin and doxorubicin is classical regimen used in the historically in the advanced PNETs. Symptomatic medical therapy that reduce insulin release in Insulinoma is, I hope if you are not able to answer it, then I'm really worried. Digoxide, option A, inhibits insulin secretion from beta cell used for the symptomatic control of pre-op or even when inoperable. First line symptomatic control of acid hypersecretion in Gastrinoma is, it is simple, high dose PPI. Option B. Which hereditary syndrome is most strongly associated with pancreatic NETs? So ME1 has high penetration by pancreatic endocrine tumors. Other associations include DHL, NF1 and DSC, rare for the PNETs. So with that, friends, we have reached this end of this video, and I hope we have added some new insight, new knowledge to your existing vast knowledge. So thank you very much, friends, and we wish you a happy learning. And for an exclusive and early access to our premium high definition content, please download our app or join the channel membership. The link for everything is given in description of this video. So we will don't forget to like and subscribe to our channel. We will come up with more knowledgeable videos. Stay tuned. Happy learning.